Hello, and thank you for joining us for Module 3. We've got a lot to cover today. Today, we're going to move into the actual diagnostic areas. We're going to talk about the incidence of those diagnostic areas occurring with substance use disorder. We'll talk about some of the medications and some of the counseling approaches. There's just a couple of other last minute things from our last session. I just want to highlight for you before we move on. Again, remembering in our last session, we talked about, first of all, the importance of doing the assessment. We need to gather as much accurate, usable information as is possible, with our lane being looking at substance use. How has the substance use impacted this individual's life in general, in terms of their relationships, their employment, their legal issues? But we also want to learn a little bit more in our assessments as to how it is that either their mental health has impacted their substance use decisions, or their substance use decisions have now had an impact on their mental health issues. So before we begin getting into each of the topic areas, mood disorders specifically today, I want to just talk about mood disorders in general as it relates to the substance use disorder world. Mood disorders, which are generally anxiety or depression, are the two diagnostic areas that we most often see as it relates to the substance use disordered clients. But as we take a look at mood disorders, one of the challenges that we have is trying to determine, is the anxiety, for example, is the depression, for example, a direct correlate to coming to terms with the reality of the situation that their use has gotten them into? So is it situational anxiety? Is it situational depression? But above and beyond that, we also want to have a better understanding of whether or not their particular substance of choice, be it alcohol, cannabis, stimulant, hallucinogens, whatever might be their substance of choice, does it have any predisposing characteristics to it that might also present as low, depressed mood or an extremely elevated or anxious mood? When we talk about substances of choice, particularly as it relates to anxiety and depression, we also want to take a look at whether or not they're withdrawing from their substance of choice. May also be manifesting with either of these two, what look like mental health symptoms, but in fact could be situational responses to their drug of choice. And then thirdly, when we talk about anxiety and depression, particularly when we talk about mood disorders in the client with substance use disorders, we do want to understand how, in fact, their substance of choice may have actually depleted some of their own neurochemicals. For example, if somebody is struggling with a stimulant use disorder, chances are very probable that they have pretty substantially depleted their neoepinephrine, their noradrenaline, their dopamine, and their serotonin, and will be presenting at some point in the recovery process, in the treatment process for sure, with what look like depressed moods or extreme anxiety. So I'm going to keep coming back to those reference points. Is it situational? Is it drug of choice related? Or is it in fact neurochemical? When we talk about it being neurochemical, there's just one other piece I want to bring to your attention. And that is, if it is a neurochemical condition, if what they're experiencing as the psychiatric disorder is actually coming from a depletion of neurochemicals in their brain, sometimes we will not see this until they've begun to abstain from their substance of choice. Their substance of choice, which had been their coping mechanism, is no longer there for them. And these long latent mental health symptomologies, in some instances that have been laying hidden possibly for years, has now resurfaced since the substance of choice is no longer there. Again, just re-emphasizing for us something that we mentioned in our last module, which is, again, the complexity of this particular population. And again, reinforces for us why yes, as trained alcohol and drug abuse professionals, we have a better understanding possibly of the substance use and its impact on behavior. But we definitely do need to have the expertise and the collaboration with our mental health professionals in trying to get a better understanding if this is a pre-existing mental health condition as well. So we start with our three big questions. You can see them on the screen. What is anxiety? How often does it occur with substance use disorder? And then how best might we approach this in our counseling? So let's talk about what actually is anxiety. Let me start off with saying that anxiety is a very normal, healthy condition. We all have situations in our life that have caused us some anxiousness, some anticipation, possibly some dread, possibly some preoccupation with that issue. As a matter of fact, and I think I mentioned this again in our previous session, many individuals over the course of the pandemic have had extreme examples of anxiety as it relates to what's going to happen to me in my life. Am I going to have a job? Am I going to be able to take care of my family? What's my risk at being exposed to COVID? What's my risk of being a transmitter of the COVID disease to other people? So anxiety has been in our backyard for a pretty extensive period of time for most of us, certainly over the course of the last 18 months. But remembering we name a mental health condition as being a relevant mental health condition when the distress, the uncomfortableness, sometimes even the pain of the condition, or the physical aspects of that condition have now begun to interfere with two or more areas of life management. So when we talk about anxiety from a pathological point of view, again, remembering we're talking about distress, we're talking about disability. It's rather ironic, of course, as we talk about substance use disorder, that it too brings with it its own unique sets of distress, disability, and discomfort as well. Excuse me. Now, one of the things that we do know about anxiety that has become now debilitating is anxiety that is beginning to present with pervasive, a pattern of more than once occurring psychological symptom, difficulty in focusing, difficulty in concentrating, difficulty sometimes in making the simplest of decisions, the possibility of being easily distracted, having a difficult time staying attentive to one task to completion. So these might be some of the psychological characteristics that we might see of anxiety. But we also want to be very familiar with and recognize the physical symptoms of anxiety. Now, there's a laundry list of physical symptoms. I'm not suggesting that every individual struggling with anxiety is going to have every single one of these every single time. Let me walk through a couple of the more classic physical symptoms of anxiety. And as I walk through these, I'd like you to think about possibly your own situation or possibly the situation of a client, family member, loved one, or friend, where you've seen some of the physical symptoms of anxiety manifest to the point of distress. One of the most common characteristics, physical symptoms, is an elevated body temperature. That's oftentimes caused by breathing in the upper lobes of our lungs. We aren't bringing breath down into our diaphragm. Individuals may, as a result of that, also experience possibly some lightheadedness or the feeling of dizziness. It's not unusual when we have some challenges, impairments, or differences in our breathing, some lightheadedness, that in fact our body doesn't go into an alarm response, and we may experience elevated heartbeats, sometimes to the extent that somebody might actually experience a condition that is known as tachycardia, which, by the way, looks very, very, very much like a heart attack. Many individuals show up in the ER of a hospital thinking, quite frankly, that what's happening to them is that they are having a cardiovascular emergency, when in fact it's an anxiety attack. We may see sweating, perspiration breakout on the forehead. We may have people report cold, clammy hands. They may talk about tingling in the tips of their fingers, numbness in their hands. Individuals will sometimes report stomach cramping as a physical symptom of their anxiety. Sometimes that stomach cramping, quite frankly, severe enough to cause frequent urination, diarrhea. We may have dramatic examples where individuals are actually defecating or urinating on themselves. We have individuals oftentimes present their physical symptoms of anxiety as having trouble falling asleep. Depending upon the level of exhaustion, depending upon what other co-occurring conditions might be going on, we might have individuals who are able to fall asleep, but they can't stay asleep. So an hour, hour and a half after drifting off to sleep, they wake up, and now they are very alert. They're very troubled. Their mind is thinking about everything that they could have, would have, should have done that day. They begin worrying about things over which they have no control. Again, just a general edginess, tension. If we're not getting the amount of sleep that we need, if we aren't getting good REM sleep, obviously this is going to affect me the next day in terms of my attentiveness. So some of it becomes almost a downward spiral. One of the psychological symptoms can trigger a physical symptom, which can trigger another psychological symptom. These all can happen in a very, very short period of time. So in many instances, absolutely, it appears as though this is some kind of either medical or mental health emergency that's presenting. Now, we talk about anxiety disorders as if it is a one size fits all, but that is not the case. There are a number of subsets or subtypes of the main diagnoses of anxiety. And again, when we talk about dual issues, we might have somebody who has anxiety presenting in more than one of these categories, along with what other mental health issues they might have, along with whatever other substance use issues they have. So again, the complexity becomes increasingly more and more obvious to us. But let me walk through these 6 general main disorders, main categories of anxiety disorders. Spend a few minutes with you on this slide. One of the relatively common anxiety disorders that people experience are what is known as a panic disorder. And nothing can explain it better than the word panic. They go into a panic. They have this premonition that something awful is going to happen. They feel like they're in a situation they might report to you that's closing in on them. They might report to you that they feel as though they're in a situation over which they have no control. And that panic feeling is very, very reinforcing. If that panic feeling has happened to someone when they've been in the checkout line in the grocery store, and let's say that they're fourth in the line, and the cashier is just taking all the time in the world with the first patron, chatting with them, the next person's getting impatient, the person after them is getting increasingly more impatient, you're getting very impatient. And you begin to feel that escalation of nervousness. How much longer is this going to take? I need to get out of here. And because that panic feeling has set in when I have been in the checkout line at a particular grocery store, the next time I need to go get groceries, I may choose to not get groceries there. Because this isn't the first time I've had to wait in line. This isn't the first time a cashier has taken more time than I thought should have been taken. So I now begin to find some place to shop that's a little less congested, maybe a little closer to home. But eventually, even that starts to have its downside. I'm now shopping at a local convenience store. I'm not at a supermarket. Most of what I need, I can get here. But I really would like to be going to my favorite grocery store, but I can't go to my favorite grocery store because I'm afraid that if I go there, I'm going to have a panic attack. You can see how this just mushrooms into quite a situation, all oftentimes in one's thought process as opposed to reality. Eventually, that individual isn't wanting to go to their favorite grocery store. They're not wanting to go to the convenience grocery store. These are the individuals who are probably unbelievably grateful that now you can have your groceries delivered to you at home, because these people don't like going to the grocery store anymore. They may have been able to talk someone to pick up their groceries for them. Say, if you're going by the grocery store, would you pick me up? Blah, blah, blah. But now that I can have my groceries delivered to my home, well, that's at least one thing around which I don't feel quite as much distress. But now I'm driving over to school to pick up my kids from school, and the traffic is bad. It's rush hour. There's a lot of people on the road. There's just been an accident up ahead of me, and that is now causing me some distress. And eventually, I'm not going to want to take that route any longer. And so on and so on. I mean, I can go on quite endlessly, actually, with situation after situation after situation of panic that feeds itself with the next situation. But eventually, this individual can develop a condition that is actually called agoraphobia, a very, very debilitating anxiety condition. Agoraphobia, by translation, is fear of the marketplace. And what it generally means is, well, fear of the marketplace, fear of being out and about, fear of being outside of my home. You want to see me, you're going to have to come here. You want to get me something and bring it here, great, but don't expect me to come to you. And the person's worldview in this agoraphobic state is getting smaller and smaller and smaller. There have been situations, you may know someone who struggled with agoraphobia to such a degree that they may well have not left their home for the last 10 or 15 years. They maybe would be willing to come out on the front steps of their front door, but they don't go down to the mailbox anymore. They don't walk out in the yard anymore. They're very, very, very withdrawn, isolated. And the reason for that is that they are fearful that they will experience a panic attack, agoraphobia, extremely debilitating. Another example of an anxiety disorder is post-traumatic stress disorder. I do want to distinguish post-traumatic stress disorder from trauma, although one would think that they are very, very much the same. They generally manifest in different sorts of ways. An individual that is struggling with an anxiety disorder that has been identified as PTSD, post-traumatic stress disorder, has gone through some, for them, what has been a horrific life experience. They have witnessed a horrible crime. They have been the victim of a horrible crime. They have seen their house burned down to the ground. They've seen a tornado come through and wipe their community literally off of the map. And anything that begins to bump up against or remind them of that situation, whether it's a show on TV, whether it's a news broadcast, whether it's a movie they're watching that might have for them some of those same triggers, their body is going to go into that same fight, flight, or freeze response that occurred for them when they experienced the trauma in the first place. And they relive that trauma over and over and over again, sometimes with very, very little provocation. It may just be a sound that provokes it. It may be a smell that provokes it. Individuals who report some PTSD from a military deployment oftentimes report that fireworks, which are a great celebration time for this individual, is extremely traumatic. So again, a debilitating reminder of something that has happened to them in the past, with their body going into exactly the same response that it went into at the time that that incident first happened. So they're reliving it over and over and over. Trauma, historical trauma, cultural oppression, trauma that might come from a violent situation where a person grew up, or a terribly abusive situation where one might have experienced trauma as a child or as a young adult, plays out in much the same way as PTSD, but it does require a little bit of a different therapeutic approach. But it is something that does fall within that anxiety domain. Now we have specific phobias. This is individuals who have some one thing that they are deathly afraid of. And deathly is probably not too far off the mark of a word. It doesn't kill them, but they go into such a hypervigilance, tachycardia, shallow breathing, body response that they are immobilized. And what might be a specific phobia for one person to somebody else would be, you got to be kidding me. Why, that's just a little spider. No, to the individual with that phobia, that spider is monstrous, it's poisonous, and there's nothing that they feel they can do to get away from it. It might be a snake, it might be the fear of heights, it might be fear of clowns. I mean, something that for other people would be like, well, that's nothing to be afraid of. To somebody, for whatever provocation has developed that phobia, again, fight, flight, or freeze. They have become incapacitated. We have individuals who might experience social phobias. Now, there's the whole dynamic of being a little shy, not being so much of an outgoing, chatty person. This is the individual who's very possibly sociable when they're with people that they know, but boy, put them in a group of people that they don't know. Have them feel obligated to attend a party or some kind of a celebration or maybe an award ceremony, and they don't know anybody else that is there. This is devastating. This is devastating to these individuals. And when we talk about substance use, by the way, this is one of the kinds of phobias where people will try to prepare themselves for that social anxiety by having a couple of drinks before they leave home. Social phobia. Again, it can be very, very debilitating. Those of us who are around this individual as family members or friends, oh, come on, listen, it'll be all right. I'll be there with you. We can try and talk them into being comfortable in a social setting. We'll come up with all kinds of, I'll have your back, I'll be your wingman. But none of that does any good, because to them, from their perspective, this is an absolutely debilitating, distressful, um, physically incapacitating kind of experience. Now, those first four are going to be real common, by the way, in the alcohol and drug abuse world. Not that we won't see items 5 or 6. So let me talk about those as well. But item 5 is the individual who is, to the point of absurdity, obsessively compulsive. We've got some people, we joke around, you're type A, you like to have things a certain way. Sure, that is not the obsessive compulsive disordered individual. This is the individual who has an anxiety disorder that has now resulted in such a degree of obsessiveness that they can't move on with even day-to-day functioning because they can't get over the obsession. Did I turn off the lights? I better go back in and make sure I turned off the lights. Well, I think I turned off all the lights. Well, wait a minute, I better go back in. I wasn't sure I turned off the basement lights. Oh, okay, well, no, I better go back in because I think I might have turned on the garage door last night, and I need to make sure that garage door is turned off as well. Oh my gosh, and I can't remember if I put on the security alarm. Well, I better go in and check it. I better trigger it, better trip the security alarm so I'm sure that it's working. And I mean, literally, they can't seem to put the right foot in front of the left foot because they have become incapacitated with their obsessiveness to some sort of attention or some sort of detail that they need to have continual over and over and over and over reaffirmation that, in fact, yes, you did. Yes, you did turn off the lights. Yes, you did turn off the iron. Yes, you did turn on the alarm. This person can't get to that place. All of the attempting to calm them and reassure them in the world is not going to be of great benefit. That obsessive compulsive disordered individual, by the way, is oftentimes a little more prevalent with individuals that have spent any time incarcerated. I can't control anything. I can't control anything. Even in my cell, I'm not sure I can control everything, but I sure can line my toothpaste, my toothbrush, my hairbrush up a certain way. And boy, by God, somebody better not touch that. So this obsessive compulsive disorder, we kind of joke about it a little bit, and I guess I'm not going to criticize that. I mean, I certainly have been teased. I've been teased about, you're so type A, you're so obsessive compulsive, probably, but it doesn't get in the way of my being able to function in my life. These individuals are incapacitated because of their obsessive compulsion to go back and check and check and recheck and recheck. We also have individuals who have just much more of just a generalized anxiety, possibly a little more difficult or challenging in its own unique way from any of these other manifestations of anxiety, because this is the individual that is hand wringing all the time. Well, what about this? And what about that? And did you remember to do this? And well, what happens if? And oh my goodness, they exhaust themselves and everybody else around them with their anxiousness about everything. Distressful and getting in the way of the ability to function in one's life. That's when these now have become issues of concern that would legitimize a more in-depth diagnosis, and also can replicate some substance use, and in some cases are made more severe by certain substances of choice. So the DSM-5, the Diagnostic Statistical Manual of Psychiatric Symptoms, version 5, is where we're going to see these listed much more specifically as it relates to observable, measurable, quantifiable symptoms. And again, doing that kind of diagnosis as a mental health diagnosis is something that we should be leaving to those individuals who have been trained in doing mental health diagnoses. But it certainly is legitimate for you as a substance use disorder professional to say, presents with manifestations, presents with symptoms similar to, presents with feedback that sounds a lot like, and certainly pass that on to the mental health professional who's going to do the diagnostic work, or on to the psychologist or the psychiatrist who's going to do more of the diagnostic work and possibly some of the medication prescribing as well. I think in its worst case scenario, what some people will report from their anxiety is not only all of these physical discomforts, not only this psychological waiting for the other shoe to drop, something bad is going to happen. I don't know what it is. I don't know when it's going to happen, but I just have this sense that something bad is going to happen. For some individuals, really progresses into extremely serious symptomology. For some individuals, it's the fear of death. You know, if this happens to me, I will die from it. If I see a snake, there's a very high probability it's a poisonous snake. And there's even a better probability that it's a poisonous snake that's going to bite me, and that bite is going to end my life. So again, the fear of dying, the fear of losing all control, the fear that they're going crazy, a reluctance on one hand to tell other people what it is that's happening, because they know it sounds crazy, but to them it's real. And I think that that's where our empathy and our compassion really has to come into play, is that for people that experience this, it's real. In much the same way, if we have a substance user who's experiencing auditory or visual hallucinations, you know, the fact that their sense is that the room is closing in on them, their sense that something's running down the wall and it's going to come on the floor, and once it gets over onto them, it's going to kill them, that's real. To them, in that moment of hallucination, that's real. So I do think that it is rather interesting to note that there are some substances in and of themselves that really lend themselves, again, as I said, to some pretty significant examples of panic disorders, agoraphobia, panic disorders, obsessive compulsive disorders, post-traumatic stress disorders, psychological thinking symptoms, but made even more real because there are also specific physical symptoms that accompany the anxiety. So how frequently is this happening in the alcohol and drug abuse world? Well, let's pull back for a few moments and let's take a look at, first of all, incidence and prevalence across the general population. Across the general population, adults across the United States experience anxiety disorders, anxiety symptoms more often than any other mental health or psychological challenge. Again, is it situational? Maybe. Is it substance related? Maybe. Is it based on real things that happened to them in their life that were unbelievably frightening? Could be. So if we take a look at that in terms of numbers, anxiety disorders are the most common mental disorders. And we know that out of the adult population in the United States, about 25%, about 1 in 4 individuals in the population will at some point in their life, for a period of time in their life, struggle with the symptomologies of anxiety disorders. If we're taking a look at the substance using client, now we've got the client that's coming into our alcohol and drug treatment programs. How frequent are they coming into our drug treatment programs, not only with substance use disorders, but also with anxiety disorders? About 1 in 4. About 1 in 4 of the clients that come into our treatment programs are coming in with a full-blown diagnosable anxiety disorder. But if we start thinking about situations, anxiousness over, now I've really done it. Now I don't know how, what am I going to do now? I'm clearing a little bit. I really screwed up. I've lost my job. I've lost my kids. I've lost where I'm going to live. I'm going to be going to jail. How am I going to handle this? So some of it is the anxiety of the situation, or the anxiety over the things that they have done while under the influence. So it can be situational anxiety that comes from their intoxicated behaviors. But it also could come from their substances of choice. So think about it for a moment, if you would. Just brainstorm a little bit in your own head. What substances out there might cause anxiety manifestations? Well, alcohol, which is generally a central nervous system depressant, in the broader scope of things, wouldn't necessarily result in mental health anxiety, but certainly situational. I've really screwed up. So now I got this situation that I need to deal with. Individuals that are marijuana users, generally at the height of their marijuana use, unless they've gotten themselves into some thing that has been contaminated, some marijuana that's been contaminated or maybe laced with PCP, we wouldn't be all that likely to see anxiety when they're using, but we may see a lot of anxiety when they cease to use. They've come to believe, their belief system is, I need this. I need this to function. And if I'm going to be giving this up, then how am I going to handle this and this and this and this in my life? So we may see some anxiety that's coming about more from withdrawing from marijuana. Might we see anxiety with some of the hallucinogens? Yeah. And that's part of the unpredictability, of course, with hallucinogens, is that two people can take exactly the same substance and have two very, very, very different kinds of experiences. One might be a rather thrilling and exciting experience, and their buddy might have just absolutely a panicky, overwhelmingly fearful experience on the same substance. So that's, again, one of the interesting dynamics that we see with substances. The same substance can manifest a little differently from one individual to another. Historically, and this may be some gender bias, let me just throw it out and kind of let you mull it over for a moment. Statistics tell us that women, people under the age of 45, those who have either experienced separation or divorce of a relationship, or those in lower socioeconomic groups, have a higher rate of anxiety disorders. And there is some data to support that. You know, is that poverty? Is that inequality? Is that people not being treated with the same respect that maybe another population of people would be treated with? I mean, there's all kinds of things that we could attribute that to. Over the years, until really relatively recently, women have been kind of poo-hooed. Oh, well, you'll get over that, honey. You're sure it's not near your period? People will very, very, in a very insensitive sort of way say, oh, well, you must have PMS, putting up with men's stuff. No, no, no. This is not what we're talking about. This is not what we're talking about. We're talking about a very debilitating kind of condition. Now, guys are not exempt from this. What we're now seeing is that men over the age of 45 also have anxiety. Sometimes as debilitating, maybe even more debilitating than the kind of anxiety that we might see women present with. But men in our culture have at least historically been acculturated to believe, well, that just comes from being head of the household. Pull up your bootstraps, fella. That's just what comes along with being the dude. You got more pressure, you got more responsibilities, put up with it. And again, what an insensitive and callous way to talk to somebody who has both a very physiological as well as psychologically distressing condition that they're struggling with. So we have this visual anxiety disorders over the course of a lifetime. One of the statistics, again, reports that close to 15% of people with anxiety disorders were found to have at least one substance use disorder. And that there is also a strong association between certain kinds of anxiety disorders, particularly panic disorders, and severe substance use disorders. But that leaves a lot of people in between, who also have distress, discomfort, apprehension, a foreboding about what it is that has happened to them in their life, what it is that's going to happen to them in their life. Now you see in this visual three overlapping circles, the blue circles. I'd like you to think about those blue circles as it relates to most of the clients with substance use disorders, and three areas in their life where they may actually be reporting a significant amount of anxiety. The first circle is what we'll call love life. Love life, all of those relationships, from our closest, most intimate personal relationship to maybe one ring out bigger, to maybe our extended family, to our parents, to our siblings, and then one more ring out, well, and then our aunts and uncles and cousins, and then one more ring out the people that we work with. And every time we open up that love life circle bigger, we're going to see individuals that might be experiencing anxiety in those particular areas. Let's go down to the next circle clockwise. And in that circle, let's put in the word livelihood. We've got love life. Now let's put in livelihood. Livelihood, we tend to think about as one's job. But we need to be more open in our perceptions of what livelihood is. Yes, for some individuals, yes, I have a job. I feel very satisfied in my job. It's meaningful to me. Others of us may have a job that is just that, a job. We don't really like it, but we need to work. We need to bring in some kind of income. So we've got love life, we've got livelihood. If my livelihood is being the best parent I can be, and now there are things that are getting in the way of my being able to care for my children and my household the way that I want to, I'm telling you, that's going to cause me some anxiety. And then with our substance using client, we'll put one more circle up, and that's legal. Love life, livelihood, or legal. Issues that the individual has become involved in, legal implications, things that they've done to get their drug while they've been under the influence of their drug, while they're getting over their drug, that has also now escalated for them an inordinate above and beyond the normal amount of anxiety in their life. Well, with most of our clients that come into us for alcohol and drug treatment, they don't come in with just one of those. No, they come in with, generally speaking, at least two, probably three of those that are occurring. Plus, who knows what other kinds of external factors there are in their life that are causing them some degree of distress, some degree of disability that's now focused back to an anxiety disorder. A few more thoughts as it relates to the co-occurrence of anxiety disorders with substance use. Let me just give you some statistics. Just let these wash over you, see if they make sense to you in terms of the clients that you're working with. One of the facts is that among substance using clients, there's a significant likelihood of having a co-occurring anxiety disorder. You know, I hope that you leave today's session fully reaffirmed with that. Yes, you will see this. Yes, you are seeing this. Yes, you have clients who, above and beyond struggling with their substance use disorders, are going to be struggling with situational, chemical, or neurochemical anxiety. Another study tells us that of those patients that were treated for substance use, about 60% of the patients in a particular study had a lifetime prevalence of anxiety disorder. Sometime in the course of their life, they had experienced anxiety symptoms severe enough that it got in the way with life management. But of those people who've come into our treatment programs, about 45% of those experienced those symptoms in the last month. So they're either coming fresh off of an anxiety episode when they're coming into treatment, or they're right smack dab in the middle of an anxiety episode when they're coming into treatment. People with substance use disorders are twice as likely to have anxiety disorders, twice as likely than the general population. Well, if the general population is coming in at around 25%, this means that at least 50% of the clients coming into our treatment programs are coming in with anxiety disorders. Some of these individuals have had their anxiety symptoms for years. This is not a new thing. This is very possibly, for some individuals, been a long time history of having anxiety disorders, situations where they felt a lot of distress or discomfort because of anxiety, and they have been medicating that with substances for quite some time. So we're asking individuals when they're coming into treatment and they tell us that they've now medicated their anxiety with their substance of choice, to now give up the one medicator that they think they might have that will help them function. Well, that's not true. I mean, there's other ways to manage anxiety, but they've become habituated to using their substances to manage their anxiety, as opposed to some of the cognitive skills, some of the behavioral skills, and so on. So again, as we start to take a look at some of those statistics co-occurring with substance use disorder, again, my sense is that if you weren't glaringly aware of how prevalent anxiety disorders are in your population of substance using clients before today, you should be aware of it now. They're there, they're in your programs. They're struggling not only with their substance use issue, but they're also trying to figure out, how am I going to manage these uncomfortable feelings, these apprehensions, these fears, these trepidations that I'm having, that I've had for a long time in my life. Now, the good news that we have about anxiety disorders is that we have actually had medications for a fair amount of time to help us with individuals with anxiety disorders. And we also have some counseling techniques that are very effective in working with anxiety disorders. So let's look at the medications. Common medications that are used in treating anxiety disorders. Now, what we need to be aware of is that there are some of these medications that are used to treat anxiety disorders that, wouldn't you know it, have a very strong predisposition to also having addictive properties to them. So we need to be very careful about how it is that we educate our substance using clients to use their medications. It's not your place as an alcohol or drug counselor to prescribe medications. It is certainly not your place to tell someone that they should cease to take their medications. But we may have a two-edged sword here where they're taking the medication for anxiety, but the very same medication that they're taking for anxiety could be compromising their sobriety. So let's look at some of the common medications. When we look at anxiety disorder, as I said, we've had medications for anxiety disorders, probably fairly well established by, the early 50s, 1952 to 1958. You'll notice one of the medications is right there in bright red, benzodiazepines. This is one of the medications that for years gone by have been prescribed for individuals with anxiety disorders, benzos. Well, wouldn't you know it? Of course, this also has a high addictive potential to it. More recently, what we've seen as it relates to common medications used for anxiety disorders are something within that broader categorization of either tricyclic antidepressants, some of the SSRIs. As a matter of fact, some of the SSRIs will be equally as effective in addressing anxiety symptoms as it will depression symptoms. Helping individuals understand why it is they're taking the medication, how it is that they need to take the medication, and that using the medication in combination with their various drugs of choice is going to be counterproductive, is what we should be doing as alcohol and drug counselors. This is one of the unfortunate places where oftentimes our clients with co-occurring disorders, let's say, for example, anxiety and substance use disorder, have been given a medication that has more of a risk factor related to abuse, maybe than other medications. They're now going to a community AA meeting. One of the old timers says, "So how you doing with your recovery? How you managing your recovery?" "Well, I'm on benzos for my anxiety." Oh my goodness. They don't even get to finish the rest of their sentence before that old timer might say, "Listen, you're not in recovery." Yes, you are, if you are taking the medication as prescribed. Remember, I mentioned last week the brochure that was created by AA National Headquarters, Alcoholism and Medication. If medication is being used as prescribed, then it is considered a reasonable intervention as it relates to co-occurring issues. You will notice for post-traumatic stress disorder, and this is alarming, there is no one medication for post-traumatic stress disorder. There's nothing that will make that go away in terms of a medication. We might help people get a better understanding of it, embrace it in a different sort of way with talk therapy. But what we might see as it relates to PTSD and medications are the medications that are going to assist with the depressive part of PTSD and then the anxiety part of post-traumatic stress disorder. One of the things that we talk about when we talk about counseling approaches as it relates specifically to anxiety is not only helping people with developing some of their life management skills, but also some of the behavioral techniques. So let's talk a little bit about that. The next slide identifies behavioral techniques. Behavioral therapy can be very, very effective for individuals that are struggling with anxiety. The challenge with a behavioral technique, for example, let's say that we have somebody who's deathly afraid of heights, so much so that they have never, ever been in an airplane. They would love to go travel around the world. There's no way, it's not in the cards for them because they would never, ever get on an airplane. And now they want to deal with that. Well, a behavioral technique would be, for example, a very long, extended process with, first of all, just talking about what about that is scary. What do you think would happen? What proof do you have? What evidence do you have? How many planes fall out of the air? Blah, 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 blah. When the individual is a little more receptive to, well, maybe not every plane does fall out of the air, the therapist might take them to the airport and just sit on the perimeters of the airport. And while they're doing their therapy, watching planes land and watching planes take off. And processing with that individual while they're doing their talk therapy, what that's like for them to see planes land and planes take off. And over a long period of time, when they've become a little more comfortable with that, doesn't feel quite as scary, let's at least go into the terminal. We'll just go into the baggage area. We won't go up into the ticket counter. And we're going to watch people getting off the plane, getting their bags. We're going to watch people seeing their loved ones embracing. We're going to see people giving flowers to their family members that they haven't seen for years. Oh my God, how wonderful that is. And eventually, over time, that individual will be able to actually go up to the next floor in the airport, to the ticket counter. Oh no, okay, the ticket counter, that does it. I mean, you wipe me out on the ticket counter. Or maybe they make it through the ticket counter, but let's just watch people go through TSA. Oh, well, they just can't handle that waiting in line and anticipating and hearing people joke about what's going to happen. And, what if that TSA guy doesn't let me get on the plane? And what if my identification isn't accurate? And what if they forgot to put my suitcase on the plane? And what if? But eventually, they might even be able to make it through the TSA line. I don't think too many airports are going to willingly let us do the next part. But if we were going to follow this through, now let's go into the jetway. Let's just go down the jetway. Oh my goodness, no, we're not going to get on a plane. But let's just go down the jetway and let's do that for several weeks. And let's talk about what that was like and how at first I couldn't even breathe. I could hardly get my breath. And then eventually I was able to get my breath, but I didn't like having people crowd around me. And then I could manage the people crowding around me. But once they got to the opening on the airplane, well, that was too much. I mean, I couldn't see myself stepping across that threshold. And then maybe they even got to go into the plane and sit down. Well, this is at least 1.5 years, 2 years behavioral therapy. It works in some circumstances for some people. And we could take any one of those other phobics and we could look at that also in just very sparse, limited short-term exposure over a long period of time to the point where we would hope that the individual becomes increasingly more and more at ease. They may not ever be comfortable with flying, but at least a little more at ease. So the behavioral techniques, one, are in part exposure, more and more intense exposure to whatever is the threatening factor. But another version of behavioral techniques is something that probably several of you already do in your programs: breathing exercises, mindfulness, visualization, bibliographies, bibliotherapies, writing about it, art therapies, different ways that people can learn to express some of those concerns. Those are examples of behavioral therapies across a wide range of possibilities that might work for some individuals as it relates to managing their anxiety. But the suggestion is that those would be done in combination with what's also called cognitive therapy. Cognitive therapy is helping people begin to understand how thoughts are developed in our mind, and of those thoughts that we have in our mind, what's based on facts and what's based on misinformation. Where do we get that information? What resources do we have that tell us that that information is in fact accurate? And trying to, over time, debunk misinformation and replace inaccurate misinformation with correct cognition. So the counseling approach of a combination of some kind of behavioral therapies along with some cognitive therapies are generally going to help the person gradually confront and tolerate that situation that is causing them this amount of anxiety. Very possibly in combination with medications, more than likely in combination with medications. There are some individuals who are able to experience a degree of success with behavioral techniques and cognitive therapy alone. Generally, medication alone is not going to be enough. We have to give people some additional ways that they can process their thoughts so that their thoughts aren't consuming them, that their thoughts aren't made up of anxiety, misinformation, misdirected or misguided information, false information, and so on. Now, that's only around the mental health issues. You can begin to see, wow, this is a lot of work, because while that's going on related to the anxiety disorder, I'm over here as the substance use disorder professional, and I'm also trying to help them process what has contributed to their substance use decision making, what kinds of things need to be laid out on the table and addressed in talk therapy around their substance use, and then what kinds of things around their substance use recovery is going to be behavioral as well. What kind of help, what kind of support do they need if in fact they're making the decision to not medicate their anxiety with alcohol? What kinds of assistance can we give them in that realm? So again, I mean, just another emphasis, very complex clients. This is a very complex set of scenarios. 50% of the clients that we see in our programs come with these co-occurring issues. Our lane is to help them with the substance use. the expertise of our mental health colleagues are there to help us with the mental health components. And together we can collaborate and hopefully provide this individual with some degree of relief from their anxiety symptoms, but also help them make lower risk decisions as it relates to their mental health issues. Anxiety and substance use disorders. Very, very complicated, but a very, very common profile that you're seeing in alcohol and drug treatment programs in Minnesota. All right, let's take a bit of a breath. We're going to go to the other diagnostic area that we want to cover in this module. We want to move now to depression. Again, what is depression? How prevalent might we see individuals struggle with depression as well as substance use disorders? What are some of the medications and what are some of the recommended counseling approaches? So in general, when we talk about depression, we're usually talking about individuals that are withdrawn. They'd prefer actually to be maybe a little more isolated. That's where they're much more comfortable than being out there right in the middle of the mix. They oftentimes tend to be very pessimistic. They have a hard time with the metaphor, is the glass half full or is the glass half empty? You look at a glass and the watermark is at the halfway point, but it's half full. No, it's half empty. So somebody with depression would tend to say, no, it's half empty. Easily discouraged. Not very optimistic. Things just probably aren't going to get a heck of a lot better. I mean, things will always be this way. In the more extreme examples, we might have individuals expressing feelings of helplessness. There's nothing I can do to, I can't change what's happening in my life. I could, maybe change a couple things I do, but it's just going to be the same. I'm going back into the same relationship, the same community, the same culture, the same living situation. Nothing's ever going to change. And along with that sense of helplessness, oftentimes comes just an overwhelming sense of hopelessness and despair. When that rolls out to the more serious examples of mental health depression, this is oftentimes where we actually have people saying things like, I just don't think there's any way I can go on. I don't know how much more of this I can tolerate. I don't think I have a right to lay my stuff on everybody around me. I mean, they've put up with plenty. They've put up with a lot with me. They probably would just be better off if I weren't here. So we may hear veiled thoughts of ending one's own life, or we may hear pretty direct statements of, I just as soon be dead. So in its worst case scenario, That is the ultimate end result of depression at its worst. It's a psychiatric disorder in which a person experiences a very, very low depressed mood on a consistent basis. Now, we've all had a bad day. I'm not suggesting that if you've had even one bad day, oh my goodness, you must be struggling with depression. What we're talking about here is a pattern where these feelings of despair, hopelessness, things are just futile, there's nothing I can do to change what's going on in my life, has been going on for quite some time, and to the individual, they don't see anything down the road that's going to bring them any rays of hope around that either. In addition to this chronic low mood, there are also some other physical symptoms that we may see going on. There may be significant impairment with sleep. One of the things that's a physical symptom of depression is oftentimes just debilitating exhaustion. I mean, debilitating exhaustion. I don't think I can get up my front 3 steps to get into my house. Oh, I managed to get into my house. And then they sit in their recliner, and that's where they are until 11 o'clock at night. And then when they finally go to bed, even though they've not done anything all evening, they're exhausted and they just kind of collapse in a heap. If they don't have co-occurring anxiety, they're probably able to fall asleep relatively quickly. That's one of the dilemmas, folks. If they've got the co-occurring disorders of anxiety and depression, even though they may be just exhausted, they may not be able to fall asleep. Or if they fall asleep, they aren't getting into REM sleep. REM sleep is absolutely essential. REM sleep is where the cells in the body renew themselves, regenerate. And so over time, without REM sleep, we are going to have individuals who are seriously sleep with serious sleep deprivation, which interestingly enough can look just like psychosis. So another example of, well, is this sleep deprivation from being depressed? Is this psychosis from thought disorder? What is this? Again, obviously why we need to have our mental health professionals assist us. People that are depressed in many ways, like individuals with anxiety, may fall asleep in just a heap of exhaustion, but they wake up. And now everything that, again, they could have, would have, should have done, they're rerunning through their heads over and over and over and over again. They look at the clock, it's only 1 hour later. They look at the clock again, it's only an hour later after that. They may drift off for an hour and a half. They look at the clock and it's only an hour and a half later and it's only 2 in the morning. Just the frustration. I gotta get to sleep. Got to get to sleep. Which, by the way, is where some individuals will choose to get up and smoke a joint, or they'll choose to get up and, have a shot of tequila to help them fall asleep. In addition to sleep deprivation or sleep impairment, there may also be a change in appetite. One of the things that's interesting with depression is that some individuals just totally lose their appetite. Nothing flips their switch. I used to enjoy such and nothing's appealing to me. And then again, we might have some individuals who are struggling with depression who are now gravitating to foods that are exceptionally high in fats or carbohydrates, comfort food, soothing food. At least the food is soothing them temporarily when nothing else seems to soothe them at all. So we can see some pretty significant changes just in diet, eating habits that might indicate that there's some depression going on. So again, this isn't just having a crummy day. This is having many crummy days in a row, many crummy days in a row. An overwhelming, I'll use this term, I hope it makes sense to folks, an overwhelming sense of darkness. Not light darkness, but just a heaviness, a darkness. I just can't see any reason to knock myself out to do something because I'm probably not going to do it right anyway, and it's probably not going to make me feel any better. Oh, well, I'm just going to stay here in bed. That's one of the things, just pull those covers up over your head, which of course exacerbates those feelings of helplessness and feelings of worthlessness. So much a part of what we see with depression. Most people that are struggling with depression are going to have very low energy. What's interesting about that as it relates to substances of choice is that this is one of the places where some individuals who are struggling with depression, quite frankly, start looking at some substances that might give them a little bit of oomph. Look, is there anything out there that'll give me some sense that I got to get up out of bed? So they may be going to substances rather than having substances that are central nervous system depressants like alcohol. They might be obviously going to the stimulant category. Now, if you were to take a look at the DSM-5, the Diagnostic Statistical Manual version 5, and you were to look up depression, I've already highlighted some of the major symptomologies, but there's a couple of others that I would like to bring your attention to. One of the things that's very common with depression is repeated episodes of what we call anhedonia. Anhedonia means that those little things in life that used to give me pleasure, those little things in life that used to bring a smile to my face, nothing, flatline, nothing really is giving me any pleasure, piques my interest in any way, shape, or form, diminished interest or pleasure. Difficulty in concentrating, difficulty in making decisions. We usually encourage somebody who's really struggling with depression to not make any major life determining decisions while they're in that dark place. Well, I'll just move. That's it. I'll just pick up and move. I'll just move across the country. Well, I'll just divorce this. I'll just whatever. And kind of a almost a frenetic effort to do something when in fact it may be exactly the last thing in the world they want to do. As I said, difficulty in concentrating, difficulty in decision making. We could ask an individual who's struggling with depression, over the course of the next 4 weeks while you're here in treatment, what would you like to work on? I don't know. I don't know. And we may think that's resistance. We may think that's defiance. It might be, could be, but they just may not know. They may not be able to go, well, I really think what I need to work on is is this. They're just so clouded with all of this stuff running simultaneously that they can't, what is the expression? They can't see the forest for the trees. They're somewhat blinded by their own impairment. And then reoccurring thoughts of death, reoccurring morbid thinking. We may have individuals who are on that continuum of lethality as it relates to suicide. Maybe it would just be better off for everybody if I just weren't here. Well, let me just collect, how would I do it? Well, let me see, I'd probably shoot myself, and I don't have any bullets. I don't even have a gun. I probably better get going on that. And so, they'll start moving toward more and more completion of that suicide. Well, one of the things that's interesting, by the way, as it relates to substance use, is that because alcohol is the primary substance of choice, you may have clients for whom this is not their preferred substance of choice, but across the board, if we were going to make a broad generalized statement, it still is very much a preferred substance of choice. It actually is a central nervous system depressant. And even though individuals have that feeling of, at least when I have a couple beers or I take a shot, at least temporarily, I have sort of that, oh, okay, that's a little jump start. A little bit of a, maybe I could do something. But eventually, rather than becoming an activity encourager, it's just one more slows everything down. Central nervous system depressant. So let's talk about the incidence and prevalence of depression occurring with our substance using clients. Well, we would have to again go back to situational. We have clients that are going to come into our programs who are now confronted with the reality of what has gone down in their life as a result of their behavior, their using behavior. They've lost a job, they've lost custody of their kids, they don't have any place to live, they got jail time hanging over their heads. I'd be sad too. I'd be, oh my God, now what do I do? So situational is certainly going to be one of the causation factors that we might see for depression. One of them might be their particular drug of choice. I mentioned last week when we talked about stimulant use. Somebody's a meth user. You can almost set your clock 6 weeks after the last consumption. Boom, we will see a major depression crash that is substance induced, or the absence of substance by that time. And then we may have some individuals who struggle with depression, has nothing to do with their substance of choice, has nothing to do with their situation. They have either a inordinately low level of dopamine and serotonin in their brain, or the serotonin and the dopamine in their brain, which is our own natural tranquilizers, has been depleted through either our substance use, the stress in our life, the trauma in our life, the fact that we are not getting good nutrition, that we aren't getting good sleep. So depression can be coming in on any one of those situational, neurochemical, withdrawal, substance of choice, or all of those. Now, the incidence and prevalence of depression along with substance use, given that it's a mood disorder, as was anxiety. It is the second most common mental health disorder. Anxiety is the first. But right there within that mood disorder category, we have depression. 32% of the people with at least one mental health issue, one mood disorder, has some form of substance use disorder. 1 in 10 Americans will experience depression in any given year. 1 in 4 of us, and I say us because I think when we start looking at that statistic, 1 in 4 Americans has somebody that means a lot to you, somebody you care deeply about, who has struggled at least over the course of a given year with one major scenario of depression. It's all around us. It's all around us. It doesn't mean that we're a weak person, doesn't mean that we're deficient, doesn't mean that we're defective. It just happens to be the chemical process that's occurring in our brain at that time. Depression accounts for about 75% of the placements in psychiatric hospitals. And it seems to be relatively consistent between males and females. Females present about 20% of the population in psych hospitals as having depression. Men represent about 15%. So it's pretty close between the genders. About 30% of the people with depressive disorders are also going to meet the criteria for substance use disorder. I personally think that statistic's a little low, particularly if we're going to start adding situational depression. If we start adding situational depression and we start looking at individuals with substance use disorders, and I have nothing to base this on other than it would seem to me that it would probably be at least 50%. And some of the most difficult times for individuals with a substance use disorder related to their episodes of depression are occurring within the first few months of recovery. First few months of you completed treatment, you got this little honeymoon period. Oh my God, everything is wonderful. Like, I just am so grateful that I've had treatment. And then it's like, wait a minute, wait a minute. This is hard. At least when I had my substance, I didn't care. At least when I had my substance, I had something to go to when I started feeling down. At least when I had my substance, I had an excuse for why I was behaving the way that I was behaving. So not only is this something that presents with a significant prevalence, 1 in 5 in treatment, but it also presents itself pretty significantly when we take a look at those first few, I'd say 6 to 8 weeks following a formal treatment experience as well. So our discussion as it relates to some of the common medications that are used for depression sound very much like what we covered when we talked about medications for anxiety. First of all, just to make a clear statement, medications are very helpful in reducing some of the symptoms of depression, especially in those cases of depression that are moderate to severe. One of the downsides that we have with the medication is what actually is the right medication, what is the right dosage of the medication, what's the right time of the day to take the medication. And our substance using clients want a feel-good experience almost instantaneously. Antidepressants are not a feel-good medication. That's not what they do. They're not a mood elevator. Antidepressants need to be taken daily. It could take anywhere from 2 to 4 weeks before there's any alleviating of some of the dark moods. There are side effects. There continues to be those medical researchers, medication researchers, who are always trying to find an antidepressant that has fewer and fewer and fewer side effects. But there's no one magic bullet, if you will. There's no one medication. This is it. This is the cat's meow. You take this medication, you won't have any side effects. And so what we're hopefully working with the individual around is, yes, there are side effects. If you didn't take the medication, what would be happening, in trying to help the individual see some value or some wisdom in alleviating some of the depression symptoms with what might be some of the less severe side effects. One of the things that oftentimes happens when individuals are taking medication is they start to feel better. Oh, well, wow, I'm feeling really better. I think I could quit this medication. And they'll just decide all by themselves on their very, very own that that's it, they're done. And they don't inform anyone that they're no longer taking their medication. Depending upon the source of the depression, it's only a matter of time. It is only a matter of time, and those depression symptoms will gradually reappear. I think that's one of the things that oftentimes we don't say enough to our clients, is that even with the right medication, there may be a relapse of your depression symptoms. So we need to keep on top of this. There's a reason you go see your psychiatrist every now and again, to have your medications checked to make sure this is still the right medication. You've got 3 bullets: tricyclic antidepressants, you've got the MAO inhibitors, and you've got the SSRIs. The most common that we see as it relates to medications for depression are the SSRIs. If somebody is going to make a decision that they no longer want to take their medication, in a perfect world, that is done with consultation with their mental health provider or their medical practitioner, and they don't just quit. We do really want to encourage people to titrate over time, take less and less and less of the medication. I think one of the other pieces of, I think it's good news. Not everybody may see it quite that way, but I think one of the pieces of good news that we have around medication for depression is that as is the case with all of the medications for mental health issues and substance use, there's a whole movement of, let's see if we can't get a better medication. So just because we have something that might have been the go-to medication even 5 years ago is not necessarily the medication that is trending right now. And there may be medications that we haven't even begun to think about, that we have no awareness of. It's not your job as an alcohol or drug counselor to be a master in psychopharmacologies, but certainly to know who it is that has that information and how they can work with you as it relates to clients with substance use issues. And then the other thing that I would want to say is that the counseling approaches for depression are very much like the counseling approaches that we also look at as it relates to anxiety, both of which, remember, both of which are mood disorders. Cognitive behavioral therapy, helping people really clarify, where did that belief system come from? What basis do you have for that being true? If that weren't true, what would you want to do instead? Really trying to get people to break out of their myths or misconceptions. One of the advantages to talk therapy as it relates to depression is it really allows the client to get better able in naming, this is when I think my depression really took off. It was when this happened to me that things got really bad, and really helping them go back to identifying factors. What's interesting is that in many instances, the very timeline in their life in which the identifying factor for their depression surfaced may also be a place on that timeline where they saw their use really take off. That would not be an unusual correlation. So the general counseling strategies as it relates to approaches would be to help the individual understand and manage feelings. That's not all that ill recommended for working around substance use as well. You know, when you're angry and you use, what does that get you? Is there something else that might be going on when you're angry besides being angry? Are you hurt? Do you feel neglected? Do you feel put down? Understanding and managing feelings. Cognitive behavioral therapies comes into play as a very important strategy, helping people change their negative thought patterns and dysfunctional beliefs into more proactive, positive thinking. The third item that you see on the overhead is sometimes one of the things that really can help an individual as it relates not only to their substance use, but also their depression, is to begin looking at family and social relationships. To what degree is your family or your social relationships condoning your use of substances and also not confronting you or not being willing to support you or assist you with your depressive episodes? Change is an important part of recovery, the change process. Just to kind of ping that a little bit into substance use disorder world, dimension 4, readiness for change. To what degree is the individual truly ready to make some changes? Or is there still some ambivalence? Well, I know I ought to do that, but if I do that, then I can't do this. And I'm not sure I'm ready to give up these things. If it means that I have to give up these things to be able to be in recovery, I'm not sure that's important enough to me. Helping them recognize that those symptoms of depression can certainly raise their head again and again and again. Reoccurring symptomologies. And to try to recognize not only the reoccurring symptoms of depression as soon as possible, but also what are the things that are triggering me to want to use my substance of choice. Again, these are some examples of where there's some nice overlap between working with substance use disordered issues and supporting the kinds of things that your client might be getting from their mental health professional. Preparing for the possibility that there is, because this is a medical condition, there is a probability, or certainly a possibility, let me say possibility, with, in some circumstances, a probability that those symptoms could revisit. And trick is, if as much as possible, to teach the client to be as tuned into that as possible. You know, I'm just feeling real edgy today. I'm not sure what's going on. I guess I really need to take a look at that. What is it? What's happening? Wow, okay, I know now why I'm feeling edgy. And I do have the option to change that situation so that I don't feel as edgy. Because if I keep on feeling edgy, it's not going to take me too terribly long to slip back a bit, and slipping back into my depression in many instances also means slipping back into my substance use as a way to medicate my depression. General, very, very broad, general counseling approaches, not unlike the things that you're already doing around the 12 core functions as it relates to substance use. Let me say one more time, however, merging that with what you're doing as the substance use professional, what the mental health provider is doing as the mental health professional, and how can we put literally put our efforts in our heads together to increase the likelihood of the client having the greatest degree of success. So that takes us to the end of the content for today. I'm waiting for some of these assignments to come in, and I know that as folks get back from their summer holidays and so on, I'll be seeing more of those. I look forward to that. But your first assignment is to create for me a case study where we are looking at anxiety disorder. It may have as a secondary issue substance use. It may have as a co-occurring issue substance use. You're going to call the shots on the extent to which you want to bring those two together, or if you're going to just deal with anxiety, I'll leave that up to you. But a narrative case study. And then the second assignment is more of the same. I would like to have a narrative case study as well as it relates to depression, but not just, well, here it is, and here's what it looks like, and here's how it walks and talks. In both of these assignments, based on the clinical strategies that we covered in today's material, along with the other clinical strategies that you're aware of in the work that you do, if you were working with that substance using client with a co-occurring anxiety disorder as an alcohol or drug counselor, what would you like to be doing? And then the same thing as a substance use disorder professional working with a client with depression, co-occurring with substance use. What would be some of the things that you think are in your lane that would be reasonable for you as the alcohol and drug counselor to be putting together in the treatment plan for that individual? So we have one more session. Just give you a thumbnail. Our next session is going to cover bipolar disorders, antisocial personality disorders, and borderline personality disorders. Again, same drill. You'll get the materials. You'll get the Zoom link. The lectures will be there for you. Anyone that has any questions, don't hesitate to contact me, Karen at edensgroup.com. Any operational issues that you have, you could pass those on to Eric. Eric at edensgroup, ERIK, Eric at edensgroup.com. So we'll see you in a few more days, and we'll do module 4, and that will put a wrap to this 12-hour serving clients with co-occurring disorders. Thank you.